I'm Dr. Fakir Abari, and this is Non-inferiority Trials. Before we talk about non-inferiority studies, let's review different types of studies. What distinguishes clinical trials from other types of studies, such as cohort studies or case control studies, is that clinical trials always have a control group. So the intervention in a randomized clinical trial is controlled by the investigators, while the intervention in a cohort study is naturally occurring phenomenon. Let's take a closer look. So randomized clinical trials, which are also referred to as randomized controlled trials, are clinical studies that patients are actually randomly assigned to one of the groups. So one group will be the control group and the other group will be the intervention group. And there may be multiple intervention groups, but regardless, you will have at least one control group. A clinical trial can also be non-randomized. So in a non-randomized control trial, you still have your control group and your intervention group. The only difference is that the patients are assigned to those groups non-randomly. And then occasionally you will see a clinical trial that has only one group. So you may ask, where is the control in if they only had one group? So occasionally you will see them use a historical control group. For example, if there's a new drug and the investigators are comparing it to an older drug that had terrible side effects, instead of having a control group where the patients will receive that drug with the terrible side effects, they will just refer to older studies and look at the effectiveness of the drug from the old studies, and then use that as a historically controlled group for their study, for the new study. And then if you do not have control groups, then you can either have a cohort study or a case control study. And the difference between cohort study and a case control study is that the cohort study, basically is just a cohort or a group of patients that are studied. Whereas in a case control, you basically match every patient in the study based on risk factors to a control subject. Now let's take a look at some examples. So example one, which is actually from the midterm exam, basically says that ceftaroline is an antibiotic. So in 2016, investigators conducted an observational study, and they collected information from 2011 to 2015. And the eligible subjects were all those who received ceftaroline, which is the antibiotic. And they were looking at the primary outcome of clinical success. So what is the design of this study? So you can see there are 5 options. So obviously this tells you this is an observational study. So we automatically can rule out choice A, randomized clinical trial, because observational studies are different than experimental studies like clinical trials. And then the next thing you look at is this study was done in 2016, and they looked back in time between the period of time of 2011 to 2015. So that's how you know that this is a retrospective study. So you can automatically eliminate prospective. So D and E are eliminated. So you're left with B and C. So between retrospective cohort study and retrospective case control study, the next question is, the patients that they included in this study, do we have any information that says that they actually matched each patient to, a control based on risk factor? And it doesn't really say that. So it's really just a cohort of patients who received the ceftaroline antibiotic. And this is a retrospective study. So it's a retrospective cohort study. So the correct answer is B. Let's take a look at another example, which is also from the midterm exam. So in this one, basically empagliflozin is an anti-diabetic drug, and they're saying that this study, investigators randomly assigned patients to receive either the anti-diabetic drug or placebo. So if the group received placebo, that means there's a control group. So if there's a control group and they actually randomly assign the patients to either the intervention or the control group, that's how you know that if this was a randomized clinical trial. So the existence of a control group tells you that this was not a cohort study. And this is done because patients are randomly assigned to either group. They didn't really need to match each patient to a control, because the reason, the only reason that you would do a case control is when studies are not done randomly. So in order to avoid any sort of bias, basically investigator will match each case in the study to a control based on risk factors. But when you have randomly assigned patients, there is no need for case control. So the correct answer is A, randomized clinical trial. So patients are randomly assigned to one of the two groups in this controlled study. So randomized clinical trial, or you could actually call this randomized control trial. It would be the same thing. Let's take a look at another example. So in 2012, investigators reviewed data from 2009 to 2011. So this already tells you that this is a retrospective study, because they looked back in time and looked at what happened between 2009 and 2011. And they looked at patients who received a class of antibiotics known as beta-lactams. And they basically looked at drug levels in patients who are obese versus non-obese. And they actually matched for risk factors such as age, gender, renal function, and a score that we call the SOFA score. So so obviously this was a retrospective study, so it's not a randomized clinical trial, so you can rule out choice A. Randomized clinical trials are always prospective. And you can also rule out choice D and E, because this is obviously a retrospective study. So between retrospective cohort study and case control study, you can see that they actually matched for control. So based on risk factor, they matched every case in the study to a control. So that's how we know that this is a retrospective case control study. So the correct answer is C. The first learning objective is distinguish between superiority and non-inferiority clinical trials. So if you remember from before, there are generally three designs of randomized clinical trials. So we already talked about superiority, and today we're going to talk about non-inferiority studies. So just a quick recap. Superiority is used when you want to show that one treatment is a lot better than another treatment. Now this can also be used to show that the study is superior. A drug is superior to placebo. So if if there's a disease where we do not have treatment for it, and we're trying to bring a new drug to the market, you can actually show that the drug is superior to placebo, and then bring it to the market. Now, oftentimes we have a standard of care for a lot of disease states. So if there already exists a treatment that's effective, and you're trying to bring a new drug to the market that's not necessarily better, but it's an alternative, because we cannot prove that it's superior to the current treatment, a better way of comparing it to the current treatment is to show that it's basically non-inferior. And non-inferior means that it's basically not worse than the current treatment. Because if it is worse than the current treatment, then it's not reasonable to have it as an alternative. And equivalence studies are used when we bring generics to the market. So the equivalence shows that the generic drug is not better, and it's also not worse than the brand name. So equivalence is something that you typically do not see, because they don't really publish it. That's for the FDA. But you will see superiority and non-inferiority published. So in superiority study, basically the primary objective is to determine the magnitude of increased benefit, because basically with the drug we want to show that it's superior to either placebo or the current treatments. And when he says when we say that we like to show the magnitude, we're talking about how much can you reduce the risk of the whatever the primary outcome is. So with the magnitude, we're talking about absolute risk reduction or relative risk reduction. Now, in modern medicine, we are fortunate that we have effective treatments for most disease states. However, some of these drugs can have a lot of side effects, as well as being expensive. So that gives us reason to bring more drugs to the market as an alternative. So if you can bring something that's less expensive or something that's better tolerated. So not necessarily more effective, but less harm, more convenient and less expensive. So non-inferiority trial is something that we use to show that the new treatment is is not necessarily superior or better than the current treatment, but it's also not much worse. And I'll explain what this not much worse means when it comes to non-inferiority. So how much worse clinicians should consider a drug to be an acceptable alternative? It actually depends on the importance of the effectiveness outcome, on the magnitude of the reduction in harm or burden achieved by the new treatment. So in non-inferiority, we have the concept of non-inferiority margin. Some people call it non-inferiority threshold, or from a statistics point of view, when it comes to calculation, we call this margin a delta or delta. So there are equations for calculating delta, which we will not get into. What you need to know is how to interpret the delta or non-inferiority margin. And this non-inferiority margin is the maximum allowable excess of outcome events that arises from the experimental treatment compared with the standard treatment. It is important to note that there is no universally accepted method for defining this margin. So every study will have a different margin. So it's up to the clinician to decide if the margin that the investigators chose makes clinical sense. So you will have to use your clinical judgment. FDA also has a guidance for industry, and they typically allow up to 10% difference. So if you have a drug that's effective and you come up with a new drug, FDA typically allows the new drug to be, up to 10% worse than the current treatment, and that would be acceptable. Anything above the 10%. It will not be acceptable. And that's just a general guidance from FDA. So different studies will also have different. So I've seen studies with 12% margin, and I've seen studies with like 2% margin. And I'll explain more of these, how to interpret these numbers. But the key point is that there's no universally accepted method to defining this. So this FDA guidance is just a tool to use when you decide, if a study's margin is good enough. That's a tool that you can use. So that brings us to the next learning objective, which is interpret clinical and surrogate endpoints used in non-inferiority trials. So remember that in superiority trials, when you have your confidence interval, by the way, these kinds of graphs are referred to as forest plots. So a forest plot basically shows you the mean estimate as a circle, and then the confidence interval as a line. So it shows you so typically a 95% confidence interval is shown like a line. You may call this like an H line, a very wide H line, and then the circle in the middle of it is the mean estimate. So in superiority studies, you do not want this confidence interval to cross the line of no difference. So the line of no difference depends. If you're looking at the absolute difference, 0 would mean no difference between the two groups. And if you're taking a ratio of the two groups, then a ratio of 1 would mean no difference. So depending on what the outcome is looking at, so if the primary endpoint is looking at the absolute difference, you don't want the confidence interval to cross 0. If the primary endpoint is looking at the ratio, like a risk ratio or the hazard ratio, you do not want the confidence interval to cross 1. So if it did not cross the line of no difference, then you claim superiority. So you would say that your intervention is superior to the control group. Now, in non-inferiority studies, it is okay to cross the line of no difference, and that's because you're not really claiming to be superior to the control group. You're just trying to show that you're not, too much worse than the control group, and that's why we have this delta. So instead of looking at the line of no difference, we look at the line of non-inferiority margin. So this NI means non-inferiority. So non-inferiority margin. So if your confidence interval doesn't cross or touch the non-inferiority margin, then you can claim non-inferiority. So you can say that your intervention group is non-inferior to control group because it did not cross delta or non-inferiority margin. Now note that any time that you claim superiority, if it's superior, it's obviously also non-inferior. So at that point, it doesn't really make sense to say non-inferior because you just claim superiority. But you can say that for scenario A, the treatment group or intervention group is superior to control group, and also it is non-inferior because it didn't cross the non-inferiority line, and also it didn't cross the line of no difference. Whereas in scenario B, you can say that intervention group is non-inferior to control group because it did not cross the margin, but it is not superior because it crossed the line of no difference. Now, note that as long as your confidence interval doesn't cross the non-inferiority margin, you can claim non-inferiority. So it doesn't matter if your point estimate is actually, less than the line of no difference or if it crosses it. So it doesn't really matter. What matters is that the upper bound of the confidence interval doesn't cross the line. So it doesn't matter where the point estimate is. So as you can see, between B and C, it doesn't really matter. Both of them claim non-inferiority, and neither of them, between B and C, are superior. Now, anytime that the confidence interval crosses the delta or non-inferiority margin, you fail to show non-inferiority. So, and there are different scenarios, so don't worry about what kind of, conclusion you can get. So, for example, if this, the confidence interval is so wide, this is basically inconclusive. But regardless, if it's inconclusive, basically you did not achieve non-inferiority. So if you had a study like this, you can say that the intervention group is not non-inferior to the control group. The same can be said about scenario E. So it doesn't matter where the point estimate is. You can say that in scenario E, your control group failed to show non-inferiority to control group. So intervention is not non-inferior to control group. Now, when it comes to scenario F, because it didn't cross non-inferiority margin, you can actually claim non-inferiority. So in choice F, it is non-inferior. So intervention is non-inferior to control group. However, because the entire confidence interval crossed the line of no difference, it's technically inferior. However, it's not too much inferior, so we are confident by saying that it is not, I should say it is non-inferior. So that's why they say it is somewhat inferior. However, because it didn't cross the non-inferiority margin, we can actually say that in choice F, intervention group is non-inferior to control group. Now, in choice G, because also it crossed the non-inferiority margin, you can say that the intervention group is not non-inferior to control group. However, because the entire confidence interval crossed the line of no difference, you can also claim inferior. So anytime the entire confidence interval has crossed the line of no difference, it is basically inferior. So what you really need to know is, you basically need to know how to identify superiority and how to identify non-inferiority. So non-inferior includes choice A. A is non-inferior. It also happens to be superior, sure, but technically choice A is also non-inferior. Choice B is non-inferior. Choice C is non-inferior. Choice F is non-inferior. and the rest of them did not achieve non-inferiority. So choice D is not non-inferior, choice E is not non-inferior, choice G is not non-inferior, and choice H is not non-inferior. So this is just another way of saying everything that I just said. So as you can see, the first one is non-inferior and superior because it didn't cross the line of no difference. Choice B is not superior, but it is non-inferior because it didn't cross the margin. Choice C is non-inferior because it didn't cross the margin, but also it is inferior because the whole thing crossed the line of no difference. The fourth one is inconclusive, but it failed to show non-inferiority because it crossed the margin. And the last one is also failing to show non-inferiority because it crossed the margin, but also inferior because the whole thing crossed the line of no difference. So make sure you spend some time and with these forest plots, and make sure you know how to interpret each scenario. The next thing that's really important when it comes to interpreting non-inferiority studies is that well, first of all, in superiority trials, it is extremely important to use a two-sided significance level, or we also can call this a two-tail test. So in a superiority study, so when you do a study, so mu or the mean is actually the mean estimate of what you find in the study. However, if you were to repeat the study, you don't always get the same thing. So you may get some deviations from what you found in the study. And, as you keep repeating the study, you get more and more values that are closer to the mean estimate in that study. And then occasionally you get things that deviate from the mean estimate from that study. But occasionally you get outliers that are way different than the point estimate. And typically these outliers can be a type 1 error. And we really want to make sure that we do not allow for type 1 error. So that's why, and the type 1 error can be deviation from the mean in either direction. So it can be either a lot lower than what we found, or it could be a lot higher. So that's why we have a two-sided significance level. In other words, when we have an alpha of 5%, we basically are saying that we do not tolerate more than a 5% chance of having a type 1 error. And however, we're going to break it into two because the type 1 error can be an outlier on this side from the mean, or it could be on the other side. So we allow 2.5% for outliers on this side and 2.5% for outliers on the other side. So that's why we call this a two-sided significance level. We're basically controlling for type 1 error in both sides of the mean estimate. And in between, we have our 95% confidence interval. And the reason we use 95% confidence interval is because we have this rule that confidence interval equals 1 minus alpha. So if we choose an alpha of 5%, then we need to use a 95% confidence interval. Now, when it comes to non-inferiority trials, you can also use two-sided significance level. But what's really common in non-inferiority trials is that we typically use a one-sided significance level. So because we use one-sided significance level, when we choose confidence intervals, it's important to use a modified version of the equation. So because we will use one-sided confidence interval. So let's say we use the one-sided alpha of 2.5%. So in other words, we're not really worried about the outliers on the other side because we're looking for non-inferiority. We're only looking for type 1 error on outliers on this side, because this is the side that's closer to the margin, and because we're really only evaluating the non-inferiority margin, we just want to make sure that we don't have outliers or type 1 error on the side that's close to the non-inferiority margin. So that's why in non-inferiority trials you will typically see a one-sided alpha. However, when you decide what kind of confidence interval you want to use, you have to, if your alpha is one-sided, you just want to multiply it by 2 because, You don't really need to worry about the other side, and then you use a 95% confidence interval. So 2 times 2.5 will give you 5, and then 5%, and then 1 minus 5% will give you a 95% confidence interval. And I'll show you some practical examples so this would make more sense. Let's look at some superiority examples that we looked at on the day that we talked about superiority studies. So this is from the Charisma trial that was basically comparing clopidogrel to placebo. So because this is a superiority study, they are trying to show that clopidogrel is superior to placebo for the primary endpoint. Now, don't worry what the primary endpoint was. I just want you to understand how to interpret the statistics of this study. So they said that in clopidogrel or the intervention group, 6.8% of the patients had the primary endpoint. So this is the percent of the events that happened in this group. So these are bad events. Basically, they were looking at, like myocardial infarction, stroke, or death. So these are bad outcomes. And 6.8% of patients in this group experienced these bad outcomes. Whereas in the control group, or the placebo group here, 7.3% of the patients experienced those bad outcomes. And they actually calculated relative risk. So basically, 6.8 divided by 7.3 will give you a 0.93. So, 0.93 is actually what they found in this study. So 0.93 is the point estimate for this study. In other words, the patients who received clopidogrel, there was a 7% relative risk reduction. So we reduced the risk by 7% if the patients received clopidogrel compared to placebo. Now, note that this relative risk is what they found in the Charisma study. So if somebody was to do this study again, they're not going to get exactly 0.93. So that brings us to the confidence interval. So the reason we calculate the confidence interval is that, I know we found 0.93 in this study, but if we were to do the study again, there's a 95% chance that we will find something between 0.83 to 1.05. So, we are 95% sure that we will have between 0.83 and 1.05. And this study, they used a two-sided alpha of 5%. In other words, if this relative risk, if you do this study again and the relative risk is 0.6, that would be a type 1 error because 0.6 would be an outlier here. So 0.6 would be a type 1 error. Again, if we do this study again and the relative risk is 1.2, 1.2 would be here, and that's an outlier. That would be a type 1 error. So that would be unacceptable. So, but we are 95% sure that if we do this again, it would be something between 0.83 and 1.05. Now, because this confidence interval actually crossed the line of no difference, so if relative risk is less than 1, that means clopidogrel would do better. And if it's greater than 1, that means the control group would do better. And because it crossed 1, we actually would say that I know there is a difference between 6.8 and 7.3. However, this difference is not statistically significant. It is not statistically significant because if we do this study again, there's a chance that they might actually be in favor of the control group. So we lost statistical significance. So in other words, clopidogrel is not superior to placebo. And that's in agreement with the p-value. So you can see the p-value is greater than your alpha. So in this case, because alpha was 5% and the p-value is greater than 5%, we will say that this is not statistically significant. And it's important to note that this p-value is for superiority. Let's look at another example. So in the SPRINT trial, they were looking at the intervention group and the control group for the primary endpoint to see if it makes a difference. Now again, this is a superiority trial and they used a two-sided alpha of 5%. And they saw that in the intervention group, 5.2% of patients had the primary endpoint versus 6.8% of the patients in the control group. And they calculate the confidence interval that goes from 0.64 to 0.89. And because this confidence interval did not cross the line of no difference, we say that there is a statistically significant difference between the two groups. So the intervention group in this case is actually superior to the control group. So the hazard ratio was 0.75. So 0.75 is what they found in the sprint trial. And if you were to do this study again, there's a 95% chance that the hazard ratio will be something between 0.64 to 0.89. And because this did not cross 1, intervention group is superior to control group, which is in agreement with the p-value. So this p-value is for superiority, and because it is less than your alpha, which is 5%, it is statistically significant. And we can, because it's statistically significant, then you can calculate the absolute risk reduction and the number needed to treat. Let's take a look at another example. So the ILLUMINATE trial actually looked at intervention versus control group for a primary endpoint. And they found that for the primary endpoint, 6.2% of the patients had the event versus 5% of the patients in the control group. And you can see that the hazard ratio was actually greater than 1. So the hazard ratio was 1.25 with a 95% confidence interval going from 1.09 to 1.44. So you can see that 1.25 is what they found in the ILLUMINATE trial. And if you were to do this study again, there's a 95% chance that it will be something between 1.09 and 1.44. Now note that this entire thing is on the other side of the line of no difference. Because it didn't cross the line, so the confidence interval doesn't really cross the line, the p-value is actually statistically significant. So the p-value is less than your alpha, which is 5%. So there's a statistically significant difference between the two groups. However, the difference is actually in favor of the control group. So in this case, intervention was not superior to control group. In fact, the control group is superior to the intervention group. And this is exactly why we need to have a two-sided alpha. Because in the previous example, we were looking at this side of the confidence interval. In this case, we're looking at the other side. So it's extremely important to have a two-sided alpha anytime you have a superiority trial. Now, that was when it comes to ratio. Occasionally, you will have a primary endpoint that they're actually looking as absolute difference. So the only thing different is that instead of a line of difference that will look at 1, the line of difference would look at 0. So 0 becomes your no difference. And that's only because you're looking at absolute difference. Otherwise, everything else would be interpreted the same way. Now let's take a look at the non-inferiority study. So examples 1 through 4 were superiority studies. Now example 5 from the Hokusai-VTE trial were basically looking at two blood thinners, so edoxaban and warfarin. And they were looking at the primary endpoint. So they said that for the primary endpoint, 3.2% of the patients in edoxaban had the event versus 3.5% with warfarin. You can see that these two numbers are pretty close to each other. 3.2 is pretty close to 3.5. And they actually calculated a hazard ratio of 0.89. So 0.89 is what they found in the Hokusai-VTE trial. And with the 95% confidence interval going from 0.7 to 1.13. Now, this is a non-inferiority trial, and they also use the two-sided alpha, which is okay. Now, note that so this confidence interval actually crossed the line of no difference. So basically, you can say that edoxaban is not superior to warfarin, because it crossed the line of no difference, which is 1. But in this case, it's okay, because we weren't really trying to prove that edoxaban is superior to warfarin. We just wanted to show that edoxaban is non-inferior to warfarin. So in this study, they actually chose a non-inferiority margin of 1.5. So 1.5 is delta, or non-inferiority margin, or non-inferiority threshold. And although this confidence interval crossed the line of no difference, which means that edoxaban is not superior to warfarin, because it didn't cross the non-inferiority margin, then we can say that edoxaban is non-inferior to warfarin. In fact, they actually give you a p-value that's statistically significant. It's important to note that this p-value is for non-inferiority. So if the p-value is for non-inferiority, obviously you can tell from the confidence interval that this is statistically significant for non-inferiority. Whereas for superiority, because it crossed 1, it's not statistically significant for superiority. So if you were to have also a p-value for superiority, the p-value for superiority would definitely be greater than your alpha, which in this case would be 0.05. So obviously they didn't report a p-value for superiority, but some studies do. So it's important to, when you look at the p-values, make sure to know if that's a p-value for non-inferiority or a p-value for superiority. So this p-value is for non-inferiority. Let's take a look at another example. So in this study, they were looking at the intervention group compared to the control group for the primary endpoint. And they found that in the intervention group, 1.6% of patients had the events versus 2.3% of the controlled of the patients in the control group having the events. And they're actually looking at absolute difference. So you can see that actually less events occurred in the intervention group. So the difference was negative 0.7, with a confidence interval going from negative 1.4 to positive 0.1. So because we're looking at absolute difference, the line of no difference is actually 0 instead of 1. And because it went from negative to positive, your confidence interval actually crossed the line of no difference. Now, in this study specifically, they used the one-sided alpha. So they didn't really care about the outliers on this side. They only wanted to account for type 1 error on this side. And the reason is because they didn't really care about superiority, because they weren't trying to show that this group is superior to the control group. Which they basically failed superiority, but they didn't really care. They just want to show that the control that the intervention group is non-inferior to the control group. So they actually chose a non-inferiority margin of 2. So what they were interested was in to account for the type 1 error on this side, because this side is the side that's close to crossing the non-inferiority margin. Whereas this other side, it didn't really matter. Even if you had outliers on this side, it would be so far away from non-inferiority margin that it wouldn't affect the results. So that's why they chose a one-sided alpha. Now they could have also chosen a two-sided alpha, which would have been okay. But my point is that using a one-sided alpha in non-inferiority studies is okay, whereas a two-sided alpha is actually required for superiority studies. So as you can see, the confidence interval didn't cross the non-inferiority margin, so the intervention group is actually non-inferior to warfarin. Now, when you look at the p-value, you can see that it is not statistically significant, and that's why you have to be careful when you interpret the p-value. In this study, they actually reported the p-value for superiority. So of course we know from the confidence interval, because it crossed the line of no difference, it is your intervention is not superior to control group. So this p-value supports that. So they are reporting the p-value for superiority, whereas for non-inferiority, because it did not cross the margin, we can definitely say that the intervention group is non-inferior to warfarin. So if they were to report a p-value for non-inferiority, it would definitely be less than your alpha. So keep that in mind when you look at p-values. Now let's take a look at another example. So this one is actually a study that was the results were shown in an abstract, but the study wasn't actually published. They're comparing the appraise girl, which is the intervention group, to the control group clopidogrel for the primary endpoint, and they found a risk ratio of 1.05 with a confidence interval going from 0.76 to 1.44. Now, as you can see, this actually crossed the line of no difference. So definitely there was no superiority of prasugrel versus clopidogrel, but this was actually a non-inferiority trial. So they were looking at a non-inferiority margin of 1.35. However, because this confidence interval crossed non-inferiority margin, prasugrel is not non-inferior to clopidogrel. So prasugrel is not superior to clopidogrel, and also prasugrel is not non-inferior to clopidogrel. They actually did not report any p-values for this study. But if they were to report p-value, both p-values for superiority and non-inferiority will be greater than the alpha. The next learning objective is given a non-inferiority trial, evaluate its internal validity. So when it comes to internal validity, basically you will ask the same questions as you would when you evaluate the internal validity of superiority study. So the first 9 questions are actually the same 9 questions that you would ask and evaluate for a superiority studies. Now, something that's specific to non-inferiority studies is, were patients analyzed in the groups to which they were randomized. So when it comes to non-inferiority studies, it's actually extremely important to have both per protocol analysis and intention to treat analysis. As I had mentioned previously, that generally in superiority studies you really want to have an intention to treat analysis, and there are some exceptions. Like for example, if you were looking for toxicity of a drug, you really want to have per protocol analysis. However, when it comes to non-inferiority studies, if you get both per protocol and intention to treat analysis, and both are in agreement, they actually make a stronger case for non-inferiority. So, not to say that, if they only included one, you cannot claim non-inferiority, but when you do journal clubs on non-inferiority, you should, look for both per protocol and intention to treat. And if they only chose one of the two analyses, then you should, that should be your criticism, that they should have done both analyses. And then the other question that you should ask is, did the investigators guard against an unwarranted conclusion for non-inferiority? So because we're looking at how much worse your intervention can do, you really want your control group to receive the best treatment. So if the control group receives suboptimal treatment, then it becomes easier to achieve non-inferiority. So, suboptimal, it could be, whether the patients are not adherent, or, based on enrollment, you can have patients that are less likely to have the outcomes. So that's really important to assess in non-inferiority studies. The other thing that's important is to actually compare the event rates in the control group compared to studies that have been done in the past. So if the number of events is actually less in the new study, it's a lot easier to achieve non-inferiority, and you should question whether this is due to differences in patient populations, or there was something specific about the study leading to less events in the control group, which makes the intervention group be easier to show non-inferiority to the control group. The last learning objective is given a non-inferiority trial, evaluate its external validity. So external validity will basically looking at generalizability of the study. So we still ask the same questions as we would ask when we evaluate superiority studies. So you want to make sure these patients are similar to our patients. We want to make sure that patient important outcomes were included in study. And something that's important about non-inferiority is that because occasionally your intervention could be a little worse than the standard treatment, but not too much worse. In other words, not more than the non-inferiority margin. This might be something to discuss to the patient, because the patient really needs to know the actual numbers. Like if we say, like, for example, if you're talking about heart attacks, you can say, so this drug will cause a little more heart attack, but not too much more. The patient may not be comfortable receiving a drug that's non-inferior to the standard treatment. So shared decision making is something that's important in modern medicine, and what shared decision making means is that uh, you know uh, uh, the patient should be included in the decision making. In other words, the physicians, the pharmacists, and also the patients should be included in the discussion when a treatment is selected for the patient, so that they know all the risks and benefits, and they can have a saying. Especially when it comes to patient preferences. That would be some important factors when choosing a treatment that's non-inferior to a standard of care. This concludes this presentation on non-inferiority trials.